let's talk about prolapse. Arguably, one of the scariest symptoms experienced by women. I want to help you understand it and have visuals of it, also know what to do about it so that it's less scary. I need to show you first the big picture and then we'll move in. The pelvis. This is the pelvis with all the pelvic floor muscles in red. There's 3 holes in the bottom of the pelvic floor. The bladder occupies that first hole and the bladder drains out of the urethra. You've got the vagina with the uterus that sit right behind, and the opening of the vagina leads into there. You've got your rectum behind that, and your rectum drains out your anus. Now, if I was to take all of those organs out of the pelvis, this is what they would look like if you were standing up. You've got support at the bottom from the pelvic floor, like a big hammock or bowl sitting at the bottom. And then all of these organs are also supported by ligaments from the top. So there are things supporting them. I think what most women visualize when it comes to prolapse is that everything just moves south or everything just falls out the bottom. But there are many different types of prolapse, and I'm going to help you understand the most common ones. Let's start with the uterine prolapse. The cervix makes up the opening into the uterus, but the uterus lives at the end of the vagina, and kind of, in most people, kind of looks like this. But when it starts to make its way down, it will start to move down into the vagina. You would feel, or if someone was doing an internal exam and they went in your vagina, the cervix usually feels like the tip of a nose, and as it starts to come down or to prolapse, you would feel that. Those women usually would notice when they're having intercourse that something feels like it's being hit with deep penetration. Maybe they feel like tampons are hitting a roadblock, or they're starting to migrate out, and or the sense of something sitting in there. So those are the big take homes of a uterine prolapse. A bladder prolapse is called a cystocele. And again, a bladder prolapse does not just mean everything just falls out of the pee tube. I want you to picture all of these organs squishy. They're not hard and rigid like this. They live together in close quarters and they live up against one another. The vagina can become squishier, especially after a vaginal delivery. And I always tell people to picture the vagina like a toilet paper roll so that you can visualize this. When the walls of the vagina aren't as firm, the bladder can encroach on it. I'm just going to move the rectum. The bladder can encroach on it and kind of push into its territory. That's a cystocele. Those people might feel when they have an internal exam that something's caving in on that wall where the bladder lives. They might notice that their pee is not fully draining, that something's being left behind. They might have urgency to pee often or either leaking a little bit. Those would be symptoms of a cystocele. A rectocele is the same as the cystocele, except for just on the other side of the vagina. So again, when the vaginal walls are a little bit stretched or thin, the rectum can encroach on the walls of the vagina and basically make the poop tube fall into the vagina tube. Those people will often notice that it's harder to get a complete bowel movement, feels like something's being left behind, or the poo's not having a nice way out. And often something like constipation can make that a lot worse because the bulk of the poo is moving through the tube and it starts to kind of expand into the vaginal wall and make it harder to come out. That's a rectocele. A rectal prolapse happens when the rectum starts to make its way out of the anus, and a urethral prolapse happens when the urethra starts to want to migrate out a little bit. Often a cystocele that pulls down into the vagina will also pull the urethra with it. Prolapse is often graded on a scale of 0 to 4, with 0 being no prolapse, 4 being that visibly something is coming out of the opening. And pelvic health physical therapists can diagnose it, family doctors can diagnose it, nurse practitioners can diagnose, but but a much more extensive diagnosis and grading will be done by a gynecologist. The most common symptoms of prolapse would be a heaviness or pressure in the vagina or the rectum, the sense that something is coming out or not sitting in the right place, or maybe you can see something is starting to come out or not sitting in the right place. Maybe when you have intercourse, it feels like something's being hit there. Maybe your tampon doesn't feel like it's sitting anymore and it's starting to migrate out. Maybe you feel like not all of your pee is emptying. It's hard to get your pee out. Maybe you have urgency with your bladder. Maybe your poo is hard to get out successfully, or you feel like it's going sideways. Maybe you need to put pressure on your perineum, or you actually need to put your finger in your vagina to feel like your poo has a place to come out. Everybody will experience these symptoms slightly different. It depends on the person, on the severity, and on what type of prolapse they have. Think of prolapse like a herniation or a hernia. Organs are starting to occupy space that they're not supposed to. Remember that the pelvic floor supports these organs from the bottom. There's ligaments and other tissues supporting from the top, and the thickness of the tissue or the quality of the tissue of these organs also matters too. I think of prolapse like a pressure issue. And what I mean by that is if the pressure downward is greater than the ability for the bottom to support it, you are at risk of prolapse. Let's talk about the reasons for prolapse in a little bit more detail. The pelvic floor. You need a pelvic floor that is reliable, that is not only strong and that can tighten and support, but that's also forgiving. If you just have a rigid group of muscles on the bottom, it can't cradle those organs nicely. You want a group of muscles that is movable, but also strong. Pressure from above. Often people will be creating too much pressure, and that's what leads to the prolapse. Things like coughing and sneezing can be big ones. Sometimes after a long cold and sneezing a lot, people notice that things feel different. Maybe you're a smoker and you have a chronic cough. Think about all the pressure that goes down to that area all the time. Sometimes you'd be surprised how people exercise. Like they hold their breath and they tense a lot of the muscles in their abs, which can create a lot of downward pressure. Sometimes it's constipation, a lot of pressure from a buildup of poo and pushing to get it out. Sometimes it can be your job. Maybe you have a job that requires a lot of heavy lifting. Or maybe you are a little bit heavier than you once used to be, and there's more weight and pressure going down through that area. The other thing is quality or thickness of tissue. And so what I mean by that is you want the walls of the vagina to be a little bit more firm, not a really squishy toilet paper roll, but one that has a nice amount of shape so that the other organs don't start to creep in on it. Something that can change that: vaginal delivery. Obviously, delivering a baby out of there stretches the walls of the vagina. Estrogen levels are a big one. Women that are nursing have lower estrogen levels, which will also contribute to thinness of tissue. Estrogen helps to keep our tissues a little bit more robust or a little bit more healthy. And menopausal women really fit into that category. As we go through menopause, our estrogen drops. And so often menopausal women will notice that symptoms of prolapse start to show up once they go through the change. Prolapse is most common in women that have had a vaginal delivery. Sometimes they notice those symptoms right after they've had their delivery. Sometimes they notice it creeps up on them. It can be associated with an increase in activity, or like I said, a cough or a cold. You've started to do some type of different exercise. A lot of women, like I said, notice that it creeps up over time and maybe really starts to show itself around menopause. It's not the same for everybody. If you have prolapse, you have options. One, you can live with it. Nothing says you have to do something about it. Your symptoms matter more than anything, and you should let those guide you. Number two, a pessary. A pessary is a device that is inserted into the vagina and helps to support the walls of the vagina. They've been labeled in the past as old lady devices, and not the case, not true at all. I think of them as knee braces for the vagina, so they can definitely come in handy for a lot of people. I'm going to be doing another interview with someone who fits pessaries, so I'm not going to go into detail in this video about them. They can be very helpful. 3, surgery. The surgeries are obviously done by surgeons, and essentially what they do is reinforce sometimes the walls of the vagina, or help to reinforce the ligaments from above. And so that sometimes is an option for people too. And obviously my favorite, pelvic health physical therapy. And we will talk a little bit more about that. I do want you to understand that all of those might be valuable for you at a different phase in the process for you. It doesn't mean you can have to choose one or the other. Sometimes you need to use a combination of several of those options. Here is how we fit in as pelvic health physical therapists. We deal a lot with the concept of supporting from the bottom and decreasing pressure from above. So we will help you with optimizing how well your pelvic floor works from the bottom and help you sort through things that might be creating pressure from above. Maybe it's how you exercise, maybe it's how you breathe, maybe it's how you lift things, maybe it's how you carry your baby. That's what we're there for. We'll assess you, how you move, and help you sort out what's at the heart of the prolapse. What I want you to understand is that we still see people that have pessaries or that will need surgery or that have had surgery, because you have to keep in mind that a pessary doesn't change the muscles. It doesn't change your habits, and neither does a surgery. They may reinforce the walls. They may help to support the ligaments, but that cannot change your muscle activity and your habits. And so to have a successful functioning body, it's good to be able to sort out all of the things contributing to the issue. So if you haven't already, if you're experiencing symptoms of prolapse or you want to be proactive in preventing it, make sure you find yourself a pelvic health physical therapist in your area. I don't think you'll be disappointed.